ESMO really was a game changer with all of this. To me, I go a little bit different direction than you, Tom. I think this patient fits so neatly into that. This is the prima type patient, and so I would have gone carbotaxol first, and then immediately, well, not immediately. That's another question: is how soon do you start your maintenance after primary chemotherapy? But then I would have transitioned into single agent niraparib. And we've been doing that since ESMO, certainly with the publication, but it's just all the more easy to do it now with the FDA indication, and it's really nice to have the nod from the FDA with the modified dosing as well, with the 77 kilogram weight and 150,000 platelets to sort of triage your patients. We were moving in that direction before, but the data keeps bearing out that that's a reasonable thing to do for these patients. You made the statement that I wouldn't observe anyone anymore. Tom, are we, Shannon, maybe I'll post Shannon. Are we in a day and age where observation is a thing of the past, or is there still a role, or where are we right now?
Well, I mean, I think it depends on the patient, right? So, I know we could, certainly argue this point, but I think that everybody needs to hear about maintenance options, and whether or not they choose to pursue them, that's up to them. I feel very strongly that patients with BRCA mutation or HRD, definitely need to strongly consider utilizing maintenance if they're, up to it. The HRP, I definitely still talk to them about it. It's certainly, if they were started on bevacizumab, I continue it. But if not, I do discuss the details around the PRIMA data as best I can. I think that there's a population that definitely is HRP, at least based on testing. And this gets at what you were talking about, Tom, where, the testing isn't perfect. There's certainly patients that benefit from PARP inhibition that are currently not identified by our testing strategies. Why is that? Is that because they have some other marker we don't know about? Maybe. Is it because our testing strategies don't identify every single patient that could benefit? Yes, obviously. So I'm really interested to do a deeper dive on those so-called HR proficient tumors that did you get a benefit from niraparib. And, so what I tell patients is there may be a chance you could benefit from this drug. Your testing says not that much. It might be a little bit, but you may be in that population that we don't know yet that could get a benefit. And I let them decide. And, I think some patients say, I'd rather take something. And even if it only gives me a few extra months, like, at least I did what I could. And I think that's reasonable. So I do talk to everybody about it, but for those HR proficient patients, I'm not as pushy as I am with the patients that actually have a biomarker.
Yeah, I completely agree. I think biomarkers are the way to go. And yeah, you present it, let them make a choice. What I think is interesting is, and what I love about PRIMA, and again, subset analysis are always fun to look at, and immature data is always fun to look and talk about. I love how the hazard ratio is flipped. The HRP group in the overall survival had the best hazard ratio, and it had the worst hazard ratio in the PFS. So obviously, as we see that data mature, but to me, I think there's no doubt about it, the HRP group, and if people believe in HRD and testing, so some people don't. So, my comment is, if you don't believe in HRD testing, I don't really ever want to hear anybody comment about what an HRP patient is, because if you don't do the test, you're not going to know who HRP is. And I hear a lot of people say that in the same term. I don't believe in HRD testing. What's the highest unmet need? The HRP proficient group. Well, hold on a second. If you're going to say that, you have to do the test. You can't.
I agree with you. I agree with you, Tom. But I think it is important to continually highlight that HRD, a cell is either HRP or HRD. It's a yes or no. And that may not be a fixed state, but the testing is only an indirect indicator of that. It does not give us a yes or no. And that's more of a challenging thing to wrap our head around. So you have to continually remind ourselves that while the cell is either HRD or HRP, the testing is all cut off, some of them fairly arbitrary and different for different tumor types. So they all have to be interpreted with a lot of caution. And we're seeing that these studies are demonstrating that we don't have a perfect fix on what that is.